Sir, we are live.
Yes, okay.
And sir, if you allow me, can we get started?
Yeah, sure, please.
Okay, sir. So greetings and a warm welcome to everyone. This is Rupsha, the assigned moderator from ClearNet. It is my sincere pleasure to extend a heartfelt welcome to all the delegates joining us across the country. We're indeed fortunate to have the valuable support of esteemed doctors, and I express my gratitude to each one of you for dedicating your time to be with us on today. Now, allow me a moment to introduce our platform, ClearNet. It stands as one of the largest live digital CME platform in India, providing a space for doctors to create and share their medical content. Now, I would like to extend a special welcome to today's distinguished speaker, Dr. Kiran Makwana, sir. Sir has completed MBBS, DNB in Family Medicine, and consultant at Bombay Hospital. Dr. Makwana brings a wealth of experience in family medicine and has achieved advanced certifications, including certificate course in evidence-based diabetes management. As a member of the National Academy of Medical Sciences, he exemplifies excellence in delivering patient-centered care and staying abreast of the latest medical advancements. And now I would like to take this opportunity to provide a brief overview of today's topic, which is impact of menopause on glycemic control in women with diabetes. So menopause significantly affects glycemic control in women with diabetes due to hormonal changes, primarily the decline in estrogen and progesterone levels. So estrogen plays a key role in glucose metabolism by enhancing insulin sensitivity and promoting healthy fat distribution. Its reduction during menopause leads to decreased insulin sensitivity, contributing to higher blood glucose levels and increased difficulty in managing diabetes. Given these challenges, women with diabetes require personalized management strategies to address the combined impact of menopause with diabetes on their overall health. In such cases, menopausal hormone therapy or MHT has demonstrated favorable results in glucose metabolism. So, without any further delay, sir, I would like to hand over this topic to you. Please proceed with your talk, sir. Over to you.
Yeah, okay. So thank you for those kind words. And let's start our topic today. That is impact of the menopause on the glycemic control in the woman with the diabetes. That's very upcoming topic, which is, under studies. There's a lot of data which is to be researched based on the patient's strata and locality. So what I'm gonna discuss today is in here on this slide. So introduction will be talking about the menopause, which is end of the reproductive life for the female, which is usually because of the decrease in estrogen level, and it causes the phenotypical, metabolic, and also biochemical changes in the body of the female. Usually, even the diabetes type 2, it advances, the risk of diabetes type 2 advances with the age, and sometimes it overlaps with the menopause. So that's what we are gonna discuss today. And HRT, so that is a hormonal replacement therapy, how much it will be effective and whether we can use it for everyone. So those things we'll be discussing today. And along with that, the lifestyle intervention, that is diet and exercise, how important it is for the diabetes and for the menopause, that we'll discuss in the detail. Okay, so if you can see my screen, risk factor for the type 2 diabetes during menopause. So here we have a Western data, but even for India, it is around 12% the prevalence of the diabetes overall in the overall population. And aging and obesity are the main factor which is causing this trend to increase. As you know, India is becoming the epitome of the diabetes capital, and it is main thing is a diet and the sedentary lifestyle. So if you see the role of menopause in the type 2 diabetes, so there is a lot of confusion and a lot of gray areas in this, because sometimes we see that research paper says that it is because of the ovarian aging, sometimes it is because of the estrogen deficiency or overall insulin resistance, which can be developed due to the chronological age. So that's what we are gonna discuss in the detail. So if you see, so there are some observational studies from the Europe, which is saying early menopause, so that is before 40 years, there is high chance of the developing diabetes against the normal menopause. So all the females who develop the menopause earlier in the life, they have higher risk of the diabetes development. And that was a 32% in the European studies. The same study they have done in China, but they have kept the age limit of 45. And that they also saw that 20% risk has increased for the diabetes. The same thing, if you see for the surgical menopause, that is the total hysterectomy along with the oophorectomy, they have seen the large increase in the diabetes onset. So that is almost around 58%. So here, if you can see, what are the causes the diabetes in the menopause? So first thing is phenotypical changes. So there will be an increase in total body mass for the any female. Usually they have the central obesity, which is very important factor for the development of the diabetes. Decrease energy expenditure because of the sedentary lifestyle. Decrease neuronal activity from the hypothalamus and decrease in the thermogenesis. All this also can cause the increased chances of the diabetes. One of the most important factor is the sarcopenia. So loss of muscle mass, which is utilizing the glucose in periphery, and also one of the complication of the diabetes is a sarcopenia, which is also contributing to the development of the diabetes. So usually female, they gain weight, they gain fat, and they lose the muscle. So we don't see much difference in the weight, but they are basically becoming more of uh, uh, we can say extra fat will be there on the body. Because of that, we have to really differentiate whether female is doing well with a health or no, and that's why the exercise and all that is advised. Along with that, the psychological morbidities, the depression is also very common with the perimenopausal females. Subsequent excessive energy intake and sedentary lifestyle, along with the stress, all this contribute to the formation or early onset of the diabetes. Along with that, we also see defect in insulin secretion and the action, that is insulin resistance. So insulin resistance increase with the age, along with the there will be decreased glucose disposal and also decreased beta cell survival, which will cause in turn decrease insulin secretion. Okay, so here we are seeing that woman with a shorter reproductive lifetime, that is less than 30. So for example, if a female is having the menarche at the age of 15 and they are having menopause at the 45, so only 30 years of the reproductive lifetime. If it is less than 30 years, they are also at the risk of the diabetes. So early onset of menopause and the shorter reproductive lifestyle, that both can cause the menopause risk of the diabetes. And also there is definitely a role of the estrogen deficiency in the development of the diabetes. So how it happens? So weight gain and fat distribution. So it is very common to see it is associated with a increase in the total body fat, and the fat distribution will be more towards the central area. That we call it as a apple shape and pear shape obesity. So as you know, this happens with a chronological age also, and it is aggravated in the postmenopausal female. Sorry. Along with that, there will be definitely less of the energy expenditure. So fat oxidation and all that will be also issue. Sarcopenia. So sarcopenia, as we discussed already, so loss of muscle mass and the strength causes a person to be more lethargic, and they will not be able to do the regular exercise. Sometimes even it will be overlapped by the truncal. So those things can cause the increase in the insulin resistance independently also. So impact of the abdominal fat, if you can see here in the slide, there will be, why it happens, because abdominal fat increases the inflammatory cytokines, and there will be decrease in the adipokines, which is causing the insulin resistance. And the sarcopenia and the insulin resistance are also directly proportional. So we see both the things together. So that will be, 1 + 1 will be 11 here, because there will be a lot of fat accumulation along with the sarcopenia. If you see in the human studies, insulin secretion and action, it will be dependent on the liver clearance also, and there will be also a change in the glucose metabolism from the liver. Insulin resistance, so pancreatic beta cell must increase the insulin secretion to maintain the homeostasis, but the dysfunction of the beta cells can lead to the diabetes. And studies have shown that menopause can also negatively impact the beta cell. And also that is the reason why euphorectomy and hysterectomy causes the beta cell deterioration and decrease in the insulin secretion. So now comes the HRT. So whether we should use it, when we should use it, and how we should use it. So indication of HRT, as we know, for the hot flushes and the night sweats. Those are the climacteric symptoms. So you have to remember 5 things for the menopause, that it will affect, it will have the vasomotor reactions, that is hot flushing, and emotional liabilities, like mood swings, that is a second M, mood swing. First one was motor symptoms. Third one is a micturating symptoms, that is a urinary incontinence. Fourth one is usually they have a musculoskeletal symptoms, that is a weakness, lethargy, the loss of muscle, and the tiredness, joint pain, all that will be seen with that. And the fifth one is a metabolic. So metabolic is a component of the diabetes. So metabolic means the lipids profile and sugar, all that will be out of control. So those 5 things you have to remember for the menopause. So those are the indication for the use of the HRT. So when and how we can use the HRT, we'll study now. So as I told you, the climacteric symptoms, that means the mood swing, and also for the hot flushes, that is climacteric symptoms. Those things we can use the HRT. What are the benefit of it? It reduces the incidence of the diabetes by 20 to 30% as for some studies. It also improves the insulin sensitivity, glucose homeostasis, and reduce the fasting glucose level. Also has a positive cardiovascular symptoms, because it also improves the lipid profile and the blood pressure. So that comorbid condition, which is there in the metabolic syndrome, it will also improve with the HRT. Okay. So also it will decrease the abdominal fat. So usually these are the hormone which will stimulate the metabolism, and that's how it will help us. So it will also decrease the abdominal fat by the enhancing the lipid oxidation and energy expenditure. It will improve the glucose metabolism by the endothelial reticulum mediated action in the liver. And estrogen directly also affect the pancreatic beta cells. Okay. So how we can give it? So there is a different mode of estrogen which we can available in the market. We can use oral, or we can use a transdermal. Oral is usually available as a Femoston mini, 0.5 by 2.5 mg ka. There is a combination of the progesterone and estrogen that you can use it to improve the insulin resistance. Also, it will improve the triglyceride, and it will decrease the inflammatory markers. Transdermal 17 beta estradiol, avoid this. There is a side effect by the oral conjugate estrogen, that is it also increases the triglyceride. This can be avoided by the using of the transdermal, that is a 17 beta estradiol cream, which is available in the cream and other form. So traditional concern, the progesterone are linked to the insulin resistance and with the effect varying by the type and dose. So we should be avoiding the metroxyprogesterone acetate, that is MPA, and levonorgestrel, because both of that has a glucocorticoid activity, and that can increase the sugar in the long term. So neutral option will be norethistérone and dietroethistérone. Those are the more neutral and can be used. So HRT guideline for the woman, when we have to use. So we have to be very, very careful when you are using it. So low CVD risk, definitely you can use the oral tablets, because it has a more effect on the estrogen, and it will improve the insulin sensitivity. But if you have patient who's obese and also have the moderate cardiovascular symptoms, then you have to be a bit careful and use the transdermal 17 beta estradiol cream, that is available as a beta gest and other things. So, and a high CVD risk and older age, more than 60, you have to be ideally avoid the HRT because they have a high risk of the cardiovascular accident and the thrombotic complications. So, as we have discussed, you have seen that a lot of studies are saying that we should be using HRT, and a lot of studies saying there is a correlation between diabetes. What are the weakness of the studies? Are they are still under the research is still going on. There are small sample size and there are some mixed finding. So still we need more studies which are supporting of this. But these are the basic guidelines which we can follow it. So again, what we have discussed here. So if you see HRT regimen, oral will be using for the lean and a very diet, which help in the weight reduction, and also it's one of the recommended diet for the diabetes. Along with that, we should also provide some micronutrients supplements like a calcium and the vitamin D, and they should limit the habits like smoking and alcohol. Next comes the exercise, where intense walking like 150 minutes per week is recommended. Along with that, we recommend female with a menopause to do some weight training because that helps in the bone health and also it improves the muscle mass. So those are the ideal things we should be prescribing to our patients. Along with that, there is a lot of patient who has attained menopause and they can't do the normal walking because of the knee problem and other things. So at least they should do the sitting exercise, like while sitting, they can just straighten up their legs. And also there is some exercise which they can do it while, even lying down. That is like squeezing the pillow in between the legs and all that, because the thigh muscle are the one of the first muscles which are getting affected by the sarcopenia in the diabetes and the menopause. So walking and some weight training is very, very important. And along with that, as we have discussed, they have to stop smoking and the alcohol if they are doing it. What are the pharmacotherapy which you should be using in case of the patient who has attained the menopause? So metformin will be the ideal because it increases the insulin sensitivity, also has a protective effect on the bone health. Also, it helps in slightly reduction of the weight. Along with that, if you want to add something, if the HbA1c is not well controlled, then you can use a neutral molecule like a DPP-4 inhibitors, which has also good effect on the bone and doesn't have much side effects. GLP-1 in case of the obese female who want to lose the weight, and along with that, they had a very good glycemic control. And those are the first line drug for the normal diabetic patient. What you should be avoiding in the female who has attained the menopause and having the diabetes is this TZ, that is a thiazolidine dinones. That is a pioglitazone because it has a lot of side effect, weight gain, the muscle loss, also had some of the other side effect like pedal edema and increase the risk of the fracture. So those is definitely no. And along with that, the SGLT2, only the one molecule, that is the canagliflozin, is avoided because it also affect the bone density and has a fracture risk also. So those are the molecules you have to avoid. Along with that, insulin, we can use it in the patient who is not well controlled with the diabetes, but we have to be very careful because it has a side effect of the increase in the weight, and also there will be hypoglycemia. So we have to modify the treatment as per the patient profile. Along with that, what we usually use is the ABCD algorithm, where we see the age of the patient, the BMI of the patient, also the comorbidities like hypertension, dyslipidemia, whether it is there, duration of the diabetes, and the expense of the medicine, that is whether patient is affordable or no. And depending on those, we select the medicines. Okay, this is also very, very important part of the bone health in the anti-diabetic therapy. If required, we also use biphosphonates in the patient with the diabetes. And also we should at least supplement them with the calcium and vitamin D, which will at least, do the baseline work. And if required, then they should be supplemented with the additional biphosphonates. So conclusion, the management of the diabetes in the menopausal female is basically start with the lifestyle, that is a diet, exercise, and then patient-specific pharmacotherapy. Individualizing the treatment is a key, and we should be very much careful about the side effect, and we should be using it with a very unique metabolic, cardiovascular, and bone health challenges during the menopause. So we should be very, very careful using the medicine, using the anti-diabetic and the HRT. Okay. So thank you so much for the patient listening. I think we can take the questions now. Thank you.
So thank you so much, sir, for this wonderful deliberation. And yes, sir, we have received a couple of questions from our participating doctors. So, sir, with all your concern, can I share my screen
Yeah,
for
please,
the
please.
Q&A? Okay.
Yeah,
Sir, may I stop your screen share from my end,
yeah, sure,
if you
sure,
don't
sure.
mind?
Yeah,
Okay.
yeah, please, please do that.
Sir, I believe my screen is visible to you.
Okay. So yeah, so we can take the questions now. So first question here comes here. So are there differences in the glycemic outcome between naturally menopause and surgically menopause diabetic women? So yeah, depending. So as we have seen also in study, the risk of the diabetes in the surgical patient increased drastically high. But at the after certain age, it is up to the patient whether they are controlling it well with the diet, exercise, and pharmacotherapy. So it's totally individual as per the patient. But yeah, I think the surgical menopause diabetic woman should be more careful because they have higher chances of developing that, and they should be more frequently checked for the diabetes, and even the sugar level should be well controlled depending on the what medicine they are taking, what is the lifestyle of the patient. Yes. Okay, next question is what are the key consideration in the managing hypoglycemia risk in the menopausal diabetic female, especially those on insulin therapy? So yeah, so whenever we are using insulin therapy, definitely, or the sulfonylureas, the risk of hypoglycemia will be increased. So what you can do is first start with a diet. So diet, the small frequent meal will help you to maintain the sugar. Second thing is they should not do the fasting. That is the third thing. And along with that, the exercise. It should not overdo the exercise. So even the exercise should be well individualized for the patient. So those are the basic factors which can cause the hypoglycemia. Along with that, when we are using the insulin, we should be using basal insulin, uh, or maybe a combined insulin like a Rhizodec, which has a long acting and a intermediate acting insulin together. So that will not cause the hypoglycemia that frequently, and it controls the sugar. I mean, the baseline sugar will be well controlled. Along with that, you can use the OHA, which is not causing the hypoglycemia. So you should not use the sulfonylureas when you are using the insulin. In those cases, we can use a more neutral molecule like a DPP-4 inhibitors or SGLT2 along with the insulin. So that we have to individualize as per the patient. But yeah, whenever you are using, try to use the long-acting or basal insulin, which will be there will be lesser chances of the hypoglycemia. Yeah. So what other strategies can be implemented to educate the menopausal diabetic woman about the dual challenge of the hormonal and glycemic change? Okay. So here as we have discussed, so how you can educate the female who has a diabetes, whether they should be using hormonal therapy and or no. So basically, depending on the phenotypical changes, what happens in the female, whether they are having the climacteric changes, definitely you can use uh, if they are perimenopausal and sugar is in good control, definitely you should consider the HRT. If patient is slightly more morbid, that is high risk of the CVD or maybe mild to moderate risk of the CVD, slight obesity, then you have to use maybe transdermal HRTs. And along with that, you should also educate them for the other things like bone health and the sarcopenia. So diet and exercise will play a very, very important part. When it comes to the patient education, we should be also tell them that they should screen their bone health with a DEXA scan every year, maybe after a certain age. They should be taking good protein in the diet for the muscle mass, doing some basic weight training. So that will be the ideal things to we start with. And also we should also promote the adult vaccination because it helps in the diabetes in some way. So sometimes we give the additional dose of the vaccines which are available in the market, like flu and other things, also should be encouraged. Along with that, we should also see whether she really has osteoporosis and whether she need extra therapy by biphosphonates along with the vitamin D and calcium. So those are the things we should counsel them and discuss with them whether they are willing for that, and then we should consider it. Yes. Okay, so what is the impact of the menopause on the pharmacokinetics and efficacy of a commonly used antidiabetic drugs such as metformin and SGLT or SGLT2? So usually, yeah. So as we have discussed, metformin is very, good molecule for a patient who has a diabetes and has attained the menopause. And sometimes we see the tolerance issue with those because the metformin is very known to cause the gastritis and all. So those patients we can give extended release formations. Along with this, they were also asked about the SGLT2 inhibitors. So as we have discussed, the canagliflozin is a contraindicated usually because of the it affects the bone health. But I think other SGLT2 can be used unless they have the micturating symptoms. That is one of the 5 symptoms of the menopause, that is urinary incontinence or recurrent urogenital infections. So in those cases, I will avoid the SGLT2 inhibitor usage also. So those are the things. And we have to also keep considering the kidney health and all that. So with the monitoring all the parameters, we can use those molecules. Yes.
So
Yeah.
thank you so much, sir. These all are the questions for today's session. Thank you for answering all the queries of our delicate doctors. And I would
Thank you.
also like to request them to stay more updated on us. You can follow us on our social media pages like Facebook, Twitter, LinkedIn, and on Instagram. So, sir, with this, I would like to conclude today's session over here and looking forward to host you again. Thank you so much, sir.
Thank you. Thank you so
Good
much.
night.
Thank you.